Welcome to another episode of CSA's podcast, Vital Times. In September of 2025, a landmark ruling by a California judge stated that non physicians could not use the term doctor in a clinical setting. This was a ruling in response to a lawsuit filed by three California based nurse practitioners in June of 2023. They were challenging the California Business and Professions Code Section 2052, which makes it a misdemeanor for non physicians to use doctor in a clinical setting or in advertisements. Judge Jesus G. Bernal wrote in an opinion that using the title doctor by non physicians in clinical contexts is inherently misleading and amounts to regulated commercial speech. Because of that, it does not fall under free speech protections. Trying to break all of this down, I am joined by three amazing physician advocates who will try and help us understand what this means and what to make of it all. Dr. Rebecca Bernard is a family physician in Fort Myers, Florida. She's a founding member and past president of Physicians for Patient Protection, a grassroots advocacy group focused on ensuring physician led care for all patients and truth and transparency among healthcare practitioners. She's also authored two books on scope of practice. Dr. Antonio Hernandez Conti is the former chair of the CSA's Legislative and Practice Affairs Division from 2019 to 2023. He then served as president from 2023 to 2024, and now, of course, is the past president. Dr. Hernandez Conti is also a partner with Southern California Permanente Medical Group and a clinical professor at the Kaiser Permanente Bernard J. Tyson School of Medicine. Dr. Christina Minor is a board certified anesthesiologist in private practice in Los Angeles. She specializes in ambulatory pediatric and obstetric anesthesiology. Dr. Minor currently serves as the president of the California Society of Anesthesiologists. She's co authored an article describing California survey data about medical titles. Hopefully, this will be an article that we'll get to during this podcast. She's a member of Physicians Protecting Patients and an active advocate for physician led care and title transparency. Welcome, all three of you, and hopefully you can really help us make sense of this ruling and what this law means. I'd like to start with you, Dr. Bernard. What is the importance, what is the significance of using the correct title in a clinical setting?
Thanks so much. And thank you for having me to discuss this really important issue. One of the things that I've realized is that in healthcare, words are more than just semantics. They're very powerful, they have important meanings, and patients need to know and be clear about the title of their clinician. First of all, having that title of doctor signifies to patients that they are, in their minds, seeing someone that completed medical school, that completed a certain amount of postgraduate training, which we call residency, and that it's standardized. You know that if you see a physician that is practicing in a particular field, that they're an expert in that field, and that one physician and another physician and another physician should be pretty equivalent as far as their knowledge base. And that's really important. That's something that was established all the way back in 1915 as part of the Flexner Report, because before that, patients really didn't know that they could trust their physician. So since then, we have standardized training, and you don't get to walk around and call yourself a doctor as a physician unless you have met these criteria. But unfortunately, what has happened, especially in about the last, I guess I'd say, decade and a half, I think starting really a lot in maybe 2010, we saw an explosion of non physician practitioners entering into clinical settings and really starting to work more without physician supervision. In the past, patients might see a nurse practitioner or a physician assistant or a nurse anesthetist, but they were always working with a physician, and that was pretty clear to most patients. Now that's evolved, and we're seeing nurse practitioners and PAs working independently. And just in the last few years, that there's been an explosion in programs that grant them doctoral level training, often called a DNP for the nurse practitioners, or a Doctor of Medical Science degree for physician assistants. Now, most of the time, those are not clinical doctorates. They tend to be leadership, informatics. They're not really giving them in any way an equivalent clinical experience to a physician, but they are now using that title of doctor. And what's happening is patients just don't know, and they're confused, and they're not sure who is a doctor. And so this ruling is so important because it helps patients to have that transparency to know, is my doctor a physician, or are they a doctor of something else? We know from surveys that patients want a physician leading their healthcare team. 84% in one study said that they want a physician in charge. They say that 88% say that only licensed medical doctors or osteopathic physicians should be able to use the title of physician. But at the same time, they say that it's not always easy to look at someone's title and know whether or not they are a physician. And frankly, the majority of them support legislation to require that it's clear for them to know. So that's, sorry, a bit lengthy answer, but the truth is that this is what patients want, and it's what they deserve.
Great. Thank you so much. That was a really thorough, I think, grounding in why this is important. So you're saying basically that the majority of patients want to know who it is that's treating them and what their credentials are. Is that correct?
That's right. And, this isn't about devaluing or undermining another clinician. We at Physicians for Patient Protection firmly believe that nurse practitioners, physician assistants, CRNAs, they all play a very important role in the healthcare team. However, it's becoming more and more difficult for patients to determine who these clinicians are. So it's not about devaluing them, it's about truth and transparency, and the fact that the training and the educational paths are not equivalent. A lot of times we hear from advocates for non-physician practitioners that they can do the same thing, they just took a different path. That's really not accurate, because it's a completely different training, a completely different amount of time, and patients really should not be misled, whether intentionally or unintentionally. I would say that the trend is to try to blur those lines even more. As an example, we see just in the last few years physician assistants trying to transition to be called physician associates, which a study that I think we'll be talking about in a moment shows that the patients are finding that even more confusing. So really, it's a matter of letting the patient know who is taking care of them so they can make the best decision for their care.
Great. Thank you. Dr. Hernandez Conti, I know you were involved with the initial, I think, law that led to the lawsuit, I guess, that was brought by the nurse practitioners. Can you tell us a little bit about what led to this law and why you think it's important?
Sure, such a great question. So let's just step back a little bit. I think first it's important to note that California has always been one of the states that has taken very strong stances in trying to protect the residents of California in a number of different sectors, whether it's the type of food they're eating and the safety around food products, or whether it's healthcare, or whether it's in the workplace. So, as far back as 1937, the California legislature, working within the Business and Professions Code section, they created a statutory law which lives in Section 2054, and that included a number of provisions related to medical care, but it also included some language specifically that described who could use the title of doctor, or the whole word doctor, DOCTOR. And really, the intent of that law was to enable persons who were consumers in the healthcare marketplace, whether they were patients or whether they were family members acting on behalf of a family member, to identify who were the physicians and doctors with the highest level of training taking care of their loved ones. So throughout the years, obviously, as technology has evolved and educational degrees have sort of come about, that law has been amended. And that law was recently amended as recently as 2024. Now, this lawsuit really all came about is because, as Dr. Bernard mentioned, there has been a proliferation of non-physicians who have basically gone out and received these doctoral type degrees. And as Dr. Bernard mentioned, many of these doctoral degrees don't really provide any additional level of clinical training. They are somewhat academic. And many of the programs are, in fact, online programs. So the persons who undergo this additional doctoral training, they don't even receive hands-on clinical training, such as that, which is standardized for physicians and surgeons and dentists and other physician specialists. So so what happened was, what really sort of triggered this all was that the state attorney general's office had identified through a series of patient complaints that there was a nurse practitioner practicing in the city of San Luis Obispo who was advertising herself as a doctor. And that nurse practitioner failed to follow all of the specific criteria that any nurse practitioner or physician extender who wishes to use the doctor prefix must adhere to without violating the statutory law. So that triggered a lawsuit. That nurse practitioner was fined $20,000. They were told to cease and desist their advertising, and that person then had to sort of withdraw their misleading advertising stating that they were a doctor per se. As a result of the attention that sort of smaller indictment led to, then three nurse practitioners decided to challenge the current statute as it stood in 2023, 2024, and really say that, hey, we're doctors too. We went and got our doctoral degrees. Why shouldn't we be allowed to use our doctor title? And so that's kind of what brought us here today. A couple of other sort of things that have come about is that, as Dr. Bernard also mentioned, is that the nurse anesthetists have also gone about getting their doctoral degrees. And within the field of anesthesiology, we have certainly noticed that there are now some nurse anesthetists who are calling themselves doctor in a clinical setting. And certainly the California Society of Anesthesiologists and the American Society of Anesthesiologists has really been on the lookout for this type of activity, which we believe, certainly here in the state of California, is misleading to patients. And so that's sort of how we got to this point in time. And we can sort of elaborate on a lot of these details a little further. But one of the things that I also just want to briefly mention is the California Society of Anesthesiologists, partnering with the California Medical Association, was able to actually update the statutory law in 2024 within the Senate Bill 1451. And we made that sort of the requirements for any practitioners who want to use that tighter doctor title setting in a clinical setting even tighter. So there are really specific indications for someone who needs to do that or wants to do that, the language that they have to use, the signage that they have to place in their offices. And part of those amendments were also challenged in that recent lawsuit.
Dr. Minor, I have a lot more questions, but I want to actually get and have Dr. Minor have an opportunity to speak as well, because I know that she was involved with a study that helped look at this. What are your thoughts around both the lawsuit and I guess the title transparency around calling yourself doctor in a clinical setting? And then if you wouldn't mind touching a little bit on the study that you referenced, that would be fantastic.
Thank you so much, Dr. Agarwal. And actually, Dr. Antonio Hernandez Conti was the lead author on that article. So we both authored this article in conjunction with our Cal Derm, which are dermatologist colleagues here in the state of California. So, I'm really glad that we're having this discussion because this is a pivotal issue. We see an intersection here of medicine, law, and public trust and title transparency. And so this federal decision, judicial opinion that came down in September, is really like Dr. Hernandez Conti said, is upholding this prior statute. And when this initial lawsuit occurred, Dr. Hernandez Conti and the CSA initiated some research, and we did uh, a survey of the public in the state of California. The California survey basically was to account for patient understanding of practitioner titles. And it was a statewide study and showed included over 1,000 adults and asked to match basically, physician and other healthcare provider titles and credentials to their training. And in our study, the only thing that was shown was 9% of California adults were able to correctly identify an actual healthcare practitioner's title with their actual training. And the majority were not able to tell the difference between a dermatologist or a nurse dermatologist, or just in the same light that Dr. Hernandez Conti mentioned, an anesthesiologist versus a nurse anesthesiologist. And so, additionally, the study showed 91% of respondents that knowing that their clinicians' qualifications were essential to make their informed consent and informed decision making about their own health care. 88% of the study's adults also supported laws that would restrict doctor or ologist titles to physicians only. And so patients, they want this clarity. They want to know who is taking care of them and is in front of them. And like Dr. Bernard mentioned earlier, when you hear doctor, most people, the majority of adults, as we showed in our study, expect that you have this medical training and additional residency training, and that you're an expert in your field. So with the recent decision, this also reiterates and reinforces what we showed in our study. And the study was published in, I don't recall the journal. It's a dermatological journal. And it really is basically one of the additional items that can be used for reference for both, in addition to things that the American Medical Association has done in their research. And for practitioners now, the implications really are important, because it does align with patient autonomy and them being aware for title transparency, for reinforcing their informed consent abilities, knowing who is taking care of them with their team integrity, and ensuring patients are aware of who's exactly responsible for their care. And actually, it will also protect non-physicians, because they will actually also be protected from misinterpretations by patients and others, by setting honest expectations. There was another article that just came out about nurse practitioners, and this was actually from the nursing literature, that they actually should not be taking care of patients independently in the emergency department. And this was also in line with making sure and ensuring that patients have the actual information who's taking care of them, and they are understanding of the care that is being provided. So where does this leave us now? So the court decision, fortunately, does reaffirm the prior Business and Professions Code, like Dr. Hernandez Conti mentioned, and the Senate bill that occurred as well, to reinforce and reaffirm these doctor titles. It also helps give us a promise of specific scope of training and accountability, both in the state of California, and this is a federal ruling in the whole country. So, we have lots of things that have happened and continue to happen, but allowing for truth and transparency and avoiding title misappropriation is something that, we at California Society of Anesthesiologists, physicians protecting patients, and the American Society of Anesthesiologists hold of utmost importance.
Thank you. That was a fabulous summary of of the importance of this. I have several questions. Dr. Hernandez Conti, you said that in 1937, the Business and Professionalism, and I forget, I'm sorry what the exact title was, had a law regarding who is and is not allowed to call themselves doctors. So that law has actually existed for for what, how many, that's almost 90 years. Is that correct? Did I hear that correctly?
Yes, that is correct. And I think that's part of California's legacy with regards to, standing, standing at the lead of all of the states and taking an active voice in protecting, the consumers who live in the state, the patients who live in the state. And I think it reflects the importance that the California legislature places in accurately identifying people with a very, very specific type of education. And I'm going to just take that a step further and put it in practical means, because as anesthesiologists, and certainly a lot of times, whether like Dr. Bernard may work in an emergency room and Dr. Minor may work in an ambulatory surgery center, and I work at a hospital, we meet our patients, in scrubs, in a paper jacket, in a hallway, and so they don't really know who we are, and so they don't see our signage, they don't meet us in an office or anything. But just as an example of how important, titles and accurate identification is in for consumers. When you walk into a hairstylist hair salon, every single hairstylist has to have their Department of Consumer Affairs from the state of California. They have their license. It has to be proudly identified and placed right on that mirror so that the person who's having their haircut knows that, okay, I'm seeing a barber, which is different from a cosmetologist, which is different from an esthetician, which is different from a number of people who may work in that sector. And so the same thing in medicine and also nursing. The California legislature feels really, really strongly in that consumers are protected when they set foot within a healthcare facility. So it is really important, and it is, I think, something to be very proud of as physicians and certainly as nurses and healthcare practitioners in this state, that we have a very, very progressive legislature that really tries to protect patients.
Dr. Minor, that's wow. I mean, I get that's mind blowing, right? That that when you go to get your hair cut, which in general is not considered life threatening or limb threatening, usually not, um, that all of these qualifications have to be displayed, and yet you can go into an emergency room or hospital and really have no idea who the people are that are there, that present themselves to you as people who are there to take care of you. I'm that image is really vivid in my mind. Dr. Minor, I wanted to follow up on one thing that you said. You said that this is it currently a federal law, or is it something that we're working on to become a federal law, that there's sort of truth in this type, the use of titles? Or is that, I thought California was a leader in that, and that's actually not true in all states. And I'll open it up also for Dr. Bernard, because I think she has addressed that in some of her books. So I'll start with Dr. Minor, if that's okay, and then move to Dr. Bernard.
Thank you so much, Dr. Agarwal. So it's actually not current federal statute. However, this most recent judicial opinion actually occurred in a federal court. So this is a federal judge who made this ruling, and so it definitely sets precedent for other states to have a similar type of law or statute. Now, this is based on a law that is statute, like in the Business and Professions Code that Dr. Hernandez Conti mentioned. It's reaffirming that existing statute in California. So that does not exist in the federal statute. However, anytime you have a judicial opinion like this, it can set forth a potential for case law and definitely set a precedent for other states moving forward. And so, the American Society of Anesthesiologists is definitely taking this as a win in the department for, medical title transparency and protection of patients, for them to be aware of who's taking care of them. And so, it's not a current federal statute, like I said, but because it does potentially set precedent, it has possibilities to expand. And you are right in California being a leader in this regard, and in general, like Tony said, or Dr. Hernandez Conti said, we've had this statute on the books for a long time, and unfortunately, it's just never been challenged. and is really, not been adhered to that often. This gives a little bit more strength and bite into that statute now.
Doc,
Um, just adding to that, it's such a great question. You would think that we would have truth and transparency laws, across the country, but there is no federal legislation. It's been kicked around about having some of it, but it's never really gone through. We have a few states that are leaders in this area. California is certainly one of them. New Jersey was had an early truth and transparency bill. Some people feel like it could be a little stronger. One of probably the strongest states is recently Georgia. They passed a very nice truth and transparency bill requiring that there be signage, that you have to wear your title, and it has to be the where you've been licensed. In other words, did you receive your license through the Board of Nursing versus the Board of Medicine? And they have some pretty good teeth in as well, as far as if it's not being followed. The question, of course, always remains, will it be enforced and will it be taken on? And I think this is why the California ruling is so important, because this is a test of whether these laws can be enforced, should be enforced. And I think that the judge's ruling is very clear to say patients should not be misled and patients need to know. I think Dr. Menor's study with Dr. Conte Hernandez is amazing. When you look at that, it's really quite shocking, because you would think if the word nurse was in the title, people would assume that's not a physician. But actually, a sizable number of people either say they definitely think that's a physician, or that they pretty well think that it's a physician. So sometimes I'll hear from NP advocates that, well, we can call ourselves doctor and we always tell people, but I'm a nurse. It's like, well, clearly, even just saying you're a nurse is not going to work for a lot of patients. So we really have to figure out a way to make sure that we're being as clear and transparent with our patients. I think California is also a leader in other ways. I think that of all the nursing statutes that I've looked at for autonomous nurses, so California does allow nurse practitioners to practice without supervision after a certain number of hours of experience. But what they've done differently that I've never seen elsewhere is the statute spells out what that nurse's expectations are. Usually, what I hear from advocates is, well, we know when we need to refer, and we just know what to do. And whereas California spells it out, like it says, if the patient is not getting better, if there is an emergency, if there is X, if there is Y, it's really clear. And I think that that is so important, because right now it's really pretty much a free for all. So people don't even know, and much less how do you enforce whether or not someone is following the statute. So kudos to your state for really trying to protect patients as much as possible in this new world that we live in.
great. Thank you. Thank you. Do you think, and again, sorry, this is kind of for all three of you, but do you think other states, and does it have to be a state by state process, or do you think there's ever a chance? And let me ask this question first. Sorry. Is there ever a chance that the federal government will pass this kind of a law, or is this really going to be a state by state effort? We'll start with Dr. Hernandez Conti.
Thanks, Dr. Agarwal. So, I think as a lot of people within the medical and nursing profession realize, every state does very tightly regulate the respective fields of the practice of medicine and nursing. Just like in every state, the practice of law is regulated. So I do not really anticipate that the federal government will, wade into, the very, very technical and sort of detailed regulatory patterns of how to ensure that their state is getting taken care of by both physicians and nurses and other non-physician extenders. I really don't. It really will probably be left to the states. But as Dr. Menor pointed out, the fact that California has this law in the books and that this ruling took place in a federal court, it does sort of create quite a bit of reverberation, and I think a little bit of precedent for other states that are starting to look at it. So, the good news is we're on the leading edge of that. But I do think certainly we're going to continue to see some of these types of cases start to come through in other states as well.
Dr. Minor, have you heard, as president of the CSA, are there other states who are interested in pursuing these kinds of laws or statutes?
Yeah, thank you, Dr. Agarwal. So, I mean, there are other states that, like Dr. Bernard mentioned, that have these types of statutes. We know that, some states, Indiana and some others, have had increased regulation and statutes passed for improved title transparency. We haven't heard anything specific after this judgment came out in the last few months. I'm sure that we'll be on the lookout for that as we go into the next session for the majority of different states for their legislation. So we don't have anything that we're aware of right now, but I know that other states are definitely considering this, especially given that this did occur in a federal court for this opinion.
No,
Yeah,
that's
I do know.
the
So I think that there is a legislation that exists in the federal regulatory language. I think I'm looking for the number 45 CFR 60.3. And so, what this is just a definition. It defines what a physician is. And it does state that a physician means doctor of medicine or osteopathy that's legally authorized by a state. And so, as far as a physician goes, they do assume that that person is licensed in the state and is a doctor of medicine or osteopathy. So, although there isn't quite the same level of protection, there is something in federal regulations that does at least give a definition. So, that is something that can be at least worked from going forward. But I agree with Dr. Hernandez Conti that this is likely going to remain at the state's control. And I know the American Medical Association continues to put forward efforts to try to get this done on the federal level. But I agree it's probably going to continue, especially since we're all licensed in our own states. We don't have a national license or anything like that. And so it's going to most likely remain at the state level with that type of regulation and statute.
great. Thank you. Dr. Bernard.
Yeah, I was just going to say that there have been two bills that have been introduced in Congress. I think one was in 2021 and another was in 2023. They were called the Truth in Healthcare Marketing Acts, and they would prohibit people from misrepresenting themselves, I guess, as in this case. Unfortunately, those bills really never went anywhere, and I don't know if that means that they're dead or if they can come back. But both of those bills were introduced by Dr. Larry Bouchon, and he is a representative from Indiana and a physician. So I think if we're going to see any movement on this, it probably is going to come from one of our physician legislators. And I think that this is an important reason why we need to elect and bring more physicians into our legislature. Perhaps that's one of the reasons why California has been successful, because you guys have had some really great physician legislators. And I think that's really where we probably need to focus our attention if we want to see positive change.
Oh, that is so interesting. I actually didn't even think about that, that the importance of physicians in the legislature is a lot of what's going to drive this. I want to, and we're getting close to time, but I do want to flip the script a little bit and ask sort of the opposite question. What is the danger if nobody controls who calls themselves what? I mean, as they say, I think I've read it somewhere. So in some of the feedback or the pushback on this ruling is that, well, Dr. Jill Biden can call herself doctor because she has a PhD in education, or I actually don't know what her exact credential is, but I know she has some kind of a doctoral degree in education. But I can't call myself doctor as a DNP, or whatever my degree is an MD. But well, what the from the people who are doing the pushback. What is the real danger for people calling themselves doctor because they have a doctoral degree of some kind in the clinical setting? And I'll start with Dr. Bernard.
Thanks so much. It's one of those things where you say, "Well, what's the big deal?" Well, it is a big deal, and I'll give you the example of Betty Wattenberger, a 6-year-old girl whose dad brought her to an urgent care because she was sick. The pediatrician wasn't available, and he suggested that they go to the pediatric urgent care. They saw a woman in a white coat who seemed like a physician. They didn't know, they didn't think to ask. That person turned out to be a pediatric nurse practitioner working by herself. Betty, there's a photograph of her in the waiting room. Her lips are blue. They're dry and cracked. She looks like she has a glassy look in her eyes. She was examined by the nurse practitioner who said, "Oh, it looks like she's got the flu. Take her home. She'll be okay." Now, of course, she was not okay. She got worse, and sadly, she ended up dying just a few hours later. So when I spoke to Jeremy about this, he's kind of on a crusade for truth and transparency, because he says if he had known, or his wife had known, that this was not a physician, they would have sought a second opinion. They would have taken their child to the emergency room. But they didn't want to question. Say, well, the doctor says she'll be okay. We'll just trust the doctor. And had they known that this was not a physician, they may have made a very different choice. So I think that's a big part of it, is just patience. They have to know whether or not they can trust the advice they're getting, and it maybe make them want to get a second opinion if they realize that maybe they need someone that has more training and more experience.
Dr. Minor, what do you think?
So I mean, I 100% agree with Dr. Bernard in this regard. I also agree that, the nurse practitioners, the nurse anesthetists, those who are advanced practice providers who have achieved a doctoral level of a degree have somewhat of a right to be able to introduce themselves as a physician, as a doctor, in certain settings. However, in the clinical setting, this is of utmost importance that there's transparency. And this example, unfortunately, where this patient was harmed ultimately from the loss of her death, a loss of her life, that it's key and critical that the public is aware of credentials and experience, because unfortunately, our PhD colleagues who, are on medical school campuses, who have, say, a PhD in biology, when they're in a setting, in a classroom, absolutely, can they be called doctor? Sure. Does anyone in that room expect that that person that has a PhD in biology is of the same credentials and training and experience that a doctor of medicine or doctor of osteopathy has? Absolutely not. And so I think the key for all of these things is the location and where and how this is being presented. This lawsuit that occurred with the judicial opinion was, basically advertising. And yes, the argument by the nurses was that this is an infringement on their free speech. And the judge disagreed and felt that this was inappropriate and basically false advertising, false presentation of their credentials. And so, if you want to be able to say, I am XYZ and I have my doctorate of nursing practice, that's a different situation than saying I'm Dr. XYZ, and then maybe even clarifying, because like we showed in our survey results in California, patients don't know. If you preface it with doctor, doesn't matter what comes on later. So the key is how it's presented, and that it is not going to be you cannot present yourself with doctor, DOCTOR, or DR before your name, no matter what your credentials are, in a clinical setting. And so, this is the best way to protect patients and have this transparency, so that hopefully, when patients do come and see you, or see an advanced practice provider who may be providing care without any physician supervision, then the public is aware of this, and like this situation, would have maybe sought out a second opinion for the sake of their child or their family member. And so I absolutely agree. And it's not discrediting, like Dr. Bernard said earlier, any of our nursing colleagues, their education or expertise, but it's all about being proud of you should, be proud of what your training is and who you are. And I strongly believe that the advanced practice nurses, advanced practice providers should be in that regard. And it also does give them some protections because you are held at a different standard and level of care in the eyes of the law. And so presenting yourself as what you are is the safest thing both for patients and for themselves.
Dr. Hernandez Conti, that was great. That was a really nice summary of why this continues to be important. Dr. Hernandez Conti, anything you want to add to that?
Yeah, I think just once again, I think to put yourself in the patient's perspective, when they're making, a healthcare decision, they not only expect to know that the person taking care of them has the highest standard and level of training, but they actually have a right to know the exact qualifications, educational degree, and amount of clinical training that person has before that person makes a decision about their own healthcare or that of a loved one. And as Dr. Menard and Dr. Bernard eloquently stated, when a patient meets someone in a white lab coat or in scrubs, and the person introduces themselves as a doctor, that patient thinks they are a physician with 4 years of college, 4 years of in-person medical school, 4 to 8 years of in-person clinical training that is about 3,000 hours a year, or like for us as anesthesiologists, we undergo 12,000 to 15,000 hours of clinical training after we graduate from medical school. That is what a person thinks is a doctor. It is not someone who may have gotten a doctoral degree online, who may have completed some sort of training online through self study, who then is awarded a doctoral degree and decides to introduce themselves as a doctor. And, that's the expectation, but it's the patient's right. I think also in California, it's really important to know that, we live in a really diverse state with people from all over the world. And when whether you speak Spanish or you speak Tagalog or you speak Chinese, another language, when someone introduces themselves in a foreign language as doctor, it literally translates, in that language as doctor. And persons from other countries also have the expectation that they're being seen by a doctor. One of the really, I think, important things about how the law has been recently tightened is that nurse practitioners, first of all, must state when they introduce themselves to patients that they are not a physician or a doctor, that they are nurse practitioners with an advanced degree. They also must inform to the patient that at any time they have a right to go and seek an additional medical opinion from someone who does have advanced training and is licensed as a physician or a doctor. So the new sort of ramped up BMP code 2054 is really, really heightened, and it gives patients the right and I think the wherewithal to sort of empower themselves to make the best healthcare decision possible. And, as Dr. Bernard and Dr. Minor have mentioned, it's not about degrading anybody else. It's really just about truth and transparency and accuracy so that our patients can be empowered to make, a very important decision about their own healthcare.
Thank you all. Before we close, because I wanted to follow up on something that I think several of you mentioned. And that's the difference in education and why maybe this is such an important part of it. I think Dr. Hernandez Conti, Dr. Minor, specifically, I just heard it in the last sessions, but you talked about a little bit about like online education versus in-person education. Um, Poorly regulated nursing education. I think Dr. Minora, at one point earlier, you brought up a paper that showed that nurses, a study done by nurses, didn't think that nurse practitioners should be practicing independently in the emergency room. Dr. Minor first, and then maybe Dr. Bernard, and then Dr. Conti. Would you mind commenting a little bit on the difference in education before we wrap up this conversation?
Sure. Thank you so much, Dr. Agarwal. So, yeah, the article that I referenced is actually in nursing management, and they for themselves have said they should not be practicing independently in the emergency department because the education and training is not equivalent for that of an emergency room physician. Like Dr. Hernandez Conti mentioned, a physician has 4 years of undergraduate school, 4 years of medical school, and then 12,000 to 16,000 of hours of in-person clinical training. A nurse practitioner typically has a 4-year bachelor's of science in nursing, 2 to 3 years for their doctoral degree or master's degree. The majority of these are either partial or in totality online. And unlike the American College of Graduate Medical Education, which very stringently regulates what our clinical training is in residency programs and internships, and the types of education you must receive, how it's received, and how you're assessed and evaluated. That does not exist in the same stringency for nurse practitioners nor certified registered nurse anesthetists. The clinical settings and rotations that nurse practitioners often endure are set up by themselves. They set them up with a physician out in the community, and they're not regulated. And it could be something as simple as I've signed off that you've been present for X number of hours. And so even the clinical hours, which may only be, around 1,000 to 2,000 hours of clinical training for a nurse practitioner, those are not even equivalent to 2,000 hours in the residency training system because of the lack of regulatory manner for their education. Nurse anesthetists may have a little bit more clinical exposure, around 2,500, 2,500 clinical hours. But a lot of these programs also are poorly regulated, and there's not a stringent group like the ACGME, like I referenced earlier. So I do think that when one is presented with someone that I'm a certified or board certified nurse practitioner in dermatology, which is being presented to patients, that's not the equivalent of a board certified dermatologist. They may have encountered about 1,000 hours of general clinical training and could have done something as easy as a weekend course in dermatology experience. And so, when these things are put out into the public, you really, really have to wonder, what the intent is. And so, we unfortunately do need to have these laws and these things in patient to protect our patients from unfortunately some bad actors that occur. I'm not saying that all of our advanced practice providers do this, nor that they're all bad actors, but unfortunately we do have to have these checks and balances in place for those who are.
Thank you. I think I said Dr. Hernandez Conti next. I can't remember.
Oh, actually, I'll defer to Dr. Bernard because
Okay.
I was waiting for her to talk.
Well, Dr. Minor did such a great job of summarizing this, and I'll just add a few minor points. One is which she pointed out the emergency nurse researcher article, and there's also one on family nurse practitioner students. It was published in 2021, and that's where we get the statistic that 59% at that time, and it's probably more now, of family nurse practitioner students attend 100% or mostly online training, and 22% attend direct entry programs, which means that anybody with a bachelor's degree in any subject can become a nurse practitioner without ever having worked a day as a nurse. Now, in that report, they surveyed nurse practitioner students that were about to graduate, and they asked them how many times they had practiced different clinical skills. And they had, less than 3 times, they had 3 to 6 times, and so on. And it was really remarkable the significant number of students who had very poor, minimal exposure with the most basic aspects of uh, clinical care, like taking a history, doing a physical examination. There were up to 5% of students who reported never having ordered a diagnostic test once or prescribed a medication one time during training. So, this was really some pretty serious deficits. And so, we have these students graduating with this minimum 500 hours in some cases. Actually, the average number of hours reported for family nurse practitioner students of clinical experience is 686 hours. And we know that's just simply in no way enough to get that breadth of knowledge and volume of patient care to be able to take care of patients safely. So the literature is just showing not only is it there a quality issue, there's a quantity issue. And then in my exploration, I'm really concerned about psychiatry because I think our patients with mental illness are some of our most vulnerable patients. And some things that I found that have really appalled me are the psychiatric nurse practitioner programs, which you can be a family nurse practitioner and then do this 1 year add on certificate. And then they'll call themselves, I'm double boarded in family practice and psychiatry. Meanwhile, to be a psychiatrist, we know that's just a whole nother ball game. And of the 500 hours that they do in the psychiatric field, they usually have no more than 100 hours of experience with children. And yet they graduate with this across the lifespan certification, meaning they can take care of children and seniors and pregnant women and all sorts of different patients. And some of these programs even allow them to do 100% of their clinical experience through telemedicine or online training. So the differences are really marked and just remarkable. We are now seeing that nurse practitioners are the number one prescribers of stimulant ADHD drugs. They are also now nationally, according to the DEA, the number one prescribers of ketamine, which may have a role for some patients, but it's certainly something that is not necessarily standard of care and carries a significant number of risks. And I think it's because they probably may not know enough to be afraid of it. There's that thing we say in medicine that you sometimes don't know what you don't know. And I think that's why, as a physician, if you've seen more things, you're a little more afraid, and you should be, because you know the things that can go wrong.
Wow. That's incredible and sort of just jaw-dropping. Yeah. I don't know what to say with that. We are out of time, and I just want to thank all three of you so much for coming and talking to us about this. I feel like there's so much more to explore here, and hopefully we can have you back another time for another episode of CSA's podcast. Thank you all for joining us today. This has been another episode of CSA's podcast, Vital Times.